Well, hello everyone, and welcome to tonight's webinar that is part of our Cancer Survivor to Financial Survivor webinar series. My name is Yeshua, and I will be facilitating this webinar on behalf of the Canadian Cancer Survivor Network. And on behalf of CCSN, I'd also like to thank you for attending tonight's webinar, Navigating Your Health Insurance Plan with Suzanne La Roche. As you may know, CCSN is no stranger to webinars for our network of patients, caregivers, and survivors. The objective of this series, however, is to provide information and resources to help improve the financial situation experienced by cancer patients, caregivers, and their families as they navigate life with and after cancer. If you'd like to learn more about CCSN, please visit our website at www.survivornet.ca. You'll find plenty of information there on us, as well as news, events, and other resources that we think you'll find helpful. Before I hand things over, I've got two quick announcements. One is that this webinar is being recorded and it will be available shortly on YouTube. The video link will be sent to the email you provided when registering, so you can share this resource or go back and watch it again if you'd like. The second is at the end of this presentation, we'll have a short Q&A session. However, you don't feel the need to wait until the end to ask your questions, please feel free to type the questions into the window at the bottom right of your screen so we can have them queued up. So with that said, CCSN is pleased to welcome our presenter for tonight, Suzanne La Roche.
Great, thank you. Can you see my slides okay?
Yeah.
Great, super. So welcome to Navigating Your Private Health Insurance Plan. I think that it's always challenging to figure out what you're covered for and what you're not covered for. And so I hope to today, sorry, I'm just having some technical difficulties at my end. I was not seeing my own slides, so that was a challenge. This session is to help you better understand how private payer coverage works and to navigate your own coverage. So my topics will be what is a private payer, private drug plan coverage, a little bit about drug plan designs, the cost of your prescription at the pharmacy, and some tips about what you should do if your drug's not covered. So with that, let's get going. So what is a private payer to begin with? Well, the first thing is that to understand their importance in the Canadian landscape, private insurance pays for about 35% of Canadian drug spend in Canada, whereas public drug plans spend a little bit more. But I think that the one thing we have to remember about this is that the type of drug and the province you reside in will have a lot to do with who pays for certain treatments. The other thing it's important to know is not all payers are insurers. So there are organizations that manage drug plans and pay drug claims but do not provide insurance. The actual situation where you provide insurance, they are actually regulated financial services that can collect premiums and insure risk. And so you may have a situation where the drug plan manager may not be the same organization that insures the risk. So you may be covered by an insurer, which are some of the traditional ones we know of, like Canada Life and Green Shield and Manulife. There are some organizations that are pharmacy benefit managers or adjudicators. And there's also what we call third-party administrators. And those are organizations that pay for drugs, often for union plans, etc.
All right, Suzanne, if I can just interrupt you for a second.
Yeah.
We're not seeing your full screen. We're kind of seeing just a quarter of it.
Yeah, and you know what's happening? Sorry, is there's a square on my screen which is my view, and so I'm just trying, like it's what you see of my face. So I don't know how to change that. Hold on a sec. I don't know how to take.
So if you go to preferences,
yeah,
there should be an option there to always keep this in front, and you can remove that or webcams. Actually, sorry, it's in the screen where you see us, where you see yourself.
Right.
You can under webcams, you can see undock webcams.
It says webcam, stop sharing my webcam, hide my webcam. How about that? Now my slides have closed, so I'm just going to open up again. Sorry, everybody. Everything can be challenging. Okay. I apologize, and we did a technical run through as well, so there's no reason for this, but it is what it is.
That's how these things go sometimes, right?
Yep. Okay. So can you see my slides?
We can see, yeah, we can see your screen. There you go.
Okay. And you can see the whole slide?
Yeah.
Okay, great.
What is a private payer? There you go.
Okay. So I left off is that there's many different providers that can pay drug claims, which can include, is my screen covered again?
No, you're good to go.
Okay, it's covered for me, so. So third-party administrators are often the organizations that pay claims for unionized type environments. So when we look at health insurance, about 10% of health insurance is for individual plans that provide coverage for one person or a family. So you choose that yourselves. But the most common health benefit plan is what we call group plans, where there is a plan sponsor who provides coverage for a group of people. It could be employees, it could be members of a union or an association, all under one contract. And so my focus today will be on group plans because individual plans are slightly different. I can answer some questions, but the focus is what I'm talking about today is group insurance. So when you look at the makeup of the insurance industry, the Canadian Life and Health Insurance Association publishes facts about their organization every year, and they represent 99% of the insurance companies in Canada. They spend about $27 million, they insure about 27 million Canadians for health benefits, which they state is nearly 70% of all Canadians. They pay out $30.4 billion in extended health benefits, and very specifically for drug benefits, they spend $13.4 billion. So when you think about a private health benefit plan, I'm going to focus primarily on private drug plan coverage because that's really what people are most concerned about. And how insurance works is the plan sponsor or the employer, and I say that because it's not always an employer that provides benefits, but they are the ones that chooses the health benefit coverage, and it's usually based on what they can afford. They select the insurer, the payer that's going to pay their claims, and they actually pay for this coverage, and so they're funding the coverage. The insurer, the payer, will determine the cost of the benefit plan. So it's based on a couple factors. One is the plan design, so what kind of coverage is provided. And they also base their premiums on past and projected claims and are responsible for paying the claims according to the contract that was set up with the plan sponsor. And that it creates the arrangement is created through an insurance contract, which is set up between the insurer and the plan sponsor. So it's a legal agreement that outlines what is covered. And that really is the boundary of the coverage. It's what's being paid for by the plan sponsor, and it's what the insurer is obligated to pay for. And this is going to be important because we're going to be talking about, like, when you get a drug claim declined, it often is declined because of the specific contract your plan sponsor has, rather than the insurer determining whether the drug is covered or not. But we'll get more into that as we go along. the other thing is, like, drug plans are like snowflakes. There's no two drug plans the same. I myself worked in the insurance industry for a long time, and I think, you know, people will say, well, does this insurer cover this drug? But each private plan is unique, even with one insurer. You could have different plan sponsors who have chosen different drug plan designs based on what they want. And even the plans can differ between one company and organization. So you may work for a company that has a different plan for the management, salaried employees, and then a different one for the union employees. But even more complex is some employers offer flexible benefits where each employee gets the chance to choose their own coverage. So you could have two people in the same job in the same department, but because they had the flexible benefits choice, their coverage might be slightly different. So I think one of the reasons I mention this is oftentimes, you know, a doctor may ask me, or a patient or a friend, and they'll say, well, is this the cover drug I need? Is it covered by this insurer? And I say, the question you need to ask, is it covered by your plan, which can be different. I don't want to spend too much time about the differences in each province, but I think there's some to be noted because and you may be from one of these provinces. So if you're in the province of Quebec, employer-sponsored drug plans must be as good as the RAMQ coverage. However, many are much better. But at minimum, if RAMQ covers the drug, the private plan has to also cover the drug. In what we call the pharmacare provinces, so BC, Saskatchewan, and Manitoba, everyone has access to public coverage once an out-of-pocket income tested deductible has been met. And so what that means is a lot of private plans, if the coverage is available through pharmacare, they'll ask the patient to shift from the private coverage to the public coverage to transfer the costs and the risk to the public plan. So those are some differences, some certain provinces that have a bit of differences than the others. So private drug plan designs, I think a lot of people go through life thinking that it's a really random decision about whether something's covered or not covered, but really what's programmed into the systems that is done in a 30-second adjudication is all binary based on the parameters that have been chosen by the plan sponsor, and then the claim is adjudicated by the payer who has set that up. And so what I wanted to share with you today is some of the components of a drug plan that help determine if something's covered or not covered. So the two main components of a drug plan are a formulary, which is really which drugs are covered. And so the plan sponsor chooses which formulary they want out of the lists that are available with each payer. And the payer is responsible for deciding which drugs go on each formulary. Plan design is the adjudication rules that are applied to a drug, which is often things like how much is covered, the co-insurance or the payment method. The plan sponsor chooses the plan design, and then the insurer payer is responsible for applying that plan design to each drug claim. So again, you know, you may know a neighbor that gets 100% coverage with the same insurer as you, and someone else gets 80% coverage, and that's not the insurer changing it up, it's actually the plan sponsor that changes that up. So a formulary is a list of prescription drugs covered by a health insurance plan. And the three most common ones, the one that people think about the most is something called a prescription by law plan. I've heard people call it an open plan. It covers all drugs that legally require a prescription. But I've put here a quote from one of the payers that say, we manage high-cost specialty drugs for all our formularies, even the traditionally open ones, so that it's really a misnomer that there are open plans anymore. There's very, very few of them. The other common type of drug plan is what's called a provincial mimic, and that's when that the plan only covers the drugs that the provincial drug plan reimburses. So it copies what's happening in the province that the plan is in. And the last one is a managed formulary, which is a limited list of eligible drugs that were determined by the payer drug review committee that they were cost effective to be covered. And that's decided by the payer who's managing the drug plan. So what do drug review committees do? Well, generally speaking, they assess evidence about new drugs. They make a clinical and economic evaluation of the drug, which informs their formulary coverage decisions and other drug claim management programs like prior authorization criteria. And unfortunately, it can take sometimes up to 6 to 12 months or more to review a new drug at a certain payer. So, just because the drug has been approved by Health Canada doesn't mean it'll be available next day with your private benefit plan. So some common benefit plan designs that you may run up against is co-payments and deductibles. So a co-payment is how much your plan sponsor pays towards the cost of the drug, and how much you have to contribute. So the most common one today is 80%, but there are some that pay 100 and there's some that pay 50. So it really depends on the type of plan you have. And a deductible is similar to a co-payment, but usually it's you pay the first X dollars of each claim. So you can pay the first $5 of each claim, or you might have you pay the first $50 or $100 in the year and your plan kicks in under that. So that's just slightly different. Generic drug plans or generic pricing means that if the drug you're using has a generic alternative, your plan may only pay up to the cost of the generic drug. You can still choose the brand name drug, but you have to pay the difference. Some plans have maximums, so they have an annual or lifetime maximum, and the number can vary, the amount of the maximum, but it might be your plan covers $10,000 lifetime or $10,000 a year. You often see that type of plan design with post-retirement benefits where people usually have access to a lot of the government coverage, and so they may be more limited. Prior authorization is the step where an insurer needs more information or a payer needs more information about your condition. They may need information from your doctor to determine if you're eligible for the drug. And so that requires some paperwork and some time for it to be reviewed. Step therapy is when they might suggest that there's a certain order in which you have to follow the drugs. And so you have a first line treatment and you can't have a second line treatment until you've tried the first. So it's some set of criteria. We have provincial integration, which I talked to you about, where you might be required in certain provinces to follow and integrate with some of the government coverage, even though you have private coverage. So I want to talk to you a little bit about the cost of prescription at the pharmacy. Now, each province has different rules and regulations about how drugs are billed at the pharmacy. So because I live in Ontario, I've used an Ontario example. This is a made-up receipt, but it gives you a flavor of what's included. And most provinces have a version of this. But what's included in this on your receipt is the cost of the drug, that you're purchasing. It includes the pharmacy's dispensing fee, and then it includes the total cost of the prescription. So it breaks down the cost of the drug and the dispensing fee separately. And usually it has a section that says patient pays. And what that means is the difference between the total cost and what your plan pays is the amount that the pharmacist needs to collect as your portion of the drug cost at the pharmacy, and they collect the rest of the amount through the processes with the insurer based on your private plan. So when we look at the cost of a drug, the cost includes the manufacturer's list price, it includes wholesaler markup, it includes pharmacy markup, and it also includes the pharmacy dispensing fee. So all these costs are factored in. So in Canada, the list price for a brand name drug is regulated by the Patent Medicine Price Review Board. However, markups and dispensing fees, there is no regulations or laws that are charged to how these are charged to private plans. So the government may have legislation and regulations, but private plans actually manage these costs via pharmacy agreements that the payer sets up with the pharmacy that limit how much they can charge for a drug. So there's a certain amount of control that way, but those are business agreements rather than regulations that are issued by the government. You may have also run into what we call a preferred pharmacy network. And that's a network of pharmacies that provide guaranteed levels of service, competitive dispensing fees, and markups for the plans that participate in the network. And when I say the plans, they're usually managed by different payers or insurers. So Canada Life has a preferred pharmacy network, Manulife has one, etc. And they can be set up in a couple different ways, and they can be a little bit more restrictive, which give more savings to the plan sponsor, and they can be less restrictive. So an example of a PPN could be a mandatory PPN, which requires members to use the PPN to be reimbursed. So if you chose to go to a different pharmacy than the one that was in their network, you may not be covered through the drug, even though your plan covers it, or even if you meet the criteria. You may also have PPNs that have what we call an incentive. So they might say, if you use the PPN, you get reimbursed 80%. If you choose to go to another pharmacy, you may only be reimbursed 50%. So they provide an incentive for you to use the preferred pharmacy network. And lastly, you can have PPNs that are optional for the plan member. And so you may save money on your portion of the claim if you go to the PPN, but you're not required to. I'm frequently asked why PPNs have been set up. Well, as you know, these drug costs can be very expensive. And then additionally, when you add in markups, for example, they become even more expensive. So the insurers and the payers have negotiated with these networks to reduce the acquisition cost of the drug so that they can save on drug costs and allow your plan sponsors, employers to offer more benefits. So the more they can save on the cost of the drugs, the more benefits they can provide. So this is one way of reducing the cost of the plan overall. Many of you, or hope all of you, if you have access to more than one plan, you can use coordination of benefits. This means that spouses can be dependent of each other's plans. Children can be a dependent of both parents' plan. And your eligible expenses can be submitted to both in sequence. And there's checks and balances in place to make sure that you won't be reimbursed more than 100% of the original claim amount. So how it works is you would submit your claim to your own benefits plan first. This is if in a spousal situation. Once the claim is paid and you received your statement of benefits or explanation of benefits, you can submit the claim for the remaining amount to your spouse's benefit plan with the statement from your own plan. In some cases, the pharmacist can facilitate this at the point of sale, but not always. If you have a child, the child's claim has to go to the benefit plan whose birthday falls earliest in the calendar year. So it's based on the month and the day and not the age. So it would be, if one spouse has a January birthday and one has a June birthday, then it's the parent that has the January birthday. Once the claim is paid, you submit it to the other parent's benefit plan and get the balance of the child's claim reimbursed. So this is a great way to make sure you maximize the coverage that you have. So I often get asked, so what happens if my drug's not covered? What do I do next? And so I have a few tips for you. So some common reasons why a drug might be declined is that the payer hasn't decided whether to cover the drug or not. So it's still under review. It may be the payer has chosen not to cover the drug for any of their plans. It could be that you did not meet the payer criteria for the drug. Your plan specifically may have a formulary that doesn't cover the drug, or potentially your plan has a maximum. So these are common reasons. I think what's important here is, in the words themselves, is trying to determine why it's not covered. And so is it because of the way the payer is managing the plan overall, or is it because your plan sponsor has chosen a plan that doesn't cover the drug? And this information is important because you need to know who to appeal to if you want to have the coverage decision reconsidered. So there's really three ways to look at this. So one is doing what we call a payer appeal, and the appeal, that's when you appeal the payer's decision on a specific patient. I say this patient because often this comes from your doctor. Maybe you have a patient support program that you're dealing with for your drug. And so if it's you're appealing the payer's rationale for not covering, that's one thing. You can also potentially, so an example of this is when the patient doesn't meet criteria, and maybe the criteria is out of sync with current clinical practices, or maybe you have exceptional circumstances. I had a situation I was involved with a few months back where the preferred drug that the payer wanted the patient to take would affect that patient's fertility, and so they wanted to bypass taking that drug, and so the doctor had to do a specific appeal. The other option is for a plan sponsor exception. So the plan that was chosen by your plan sponsor, asking them for an exception. The challenge with this one is that it requires you to disclose your condition to your employer, and not everybody is willing to do that. But in doing so, you can potentially look at some of the factors that were built into your plan design and explain to them why that doesn't work for you, or why you need access despite the plan not covering. And then there's also what I call advocacy, which is really, it's not a patient specific situation, but it's a systemic issue. So I knew of a drug that was approved by Health Canada, and the payer, it was 12 to 18 months later, and they still had not made a decision to cover or not cover. You might want to dispute the criteria or the processes and help raise the bar for all patients who might need access. So that's less patient specific and overall advocacy. So if you're thinking about asking your employer or plan sponsor for exception, you need to remember a couple things, is that the premiums they're paying is based on the plan design they chose, which is really what drugs are covered. If they ask the insurer for an exception, it's considered extra contractual because it's outside the contract and the price that's been set. And depending on the size and financial arrangements of your employer, your plan sponsor, if they chose to pay for the drug, they have some risks they need to consider. So one, the cost could go up. Either their premiums will go up, or they have a feature called cost plus, where they will have to pay for the cost of the drug plus an additional fee to have an extra contractual exception made. But more importantly, there might be some legal liability through an employment inequity, where if they pay for especially pay for a drug for one employee and not others, it could result in a grievance, a human rights complaint, or even some precedent setting where they might have to continue to cover drugs in that way. So there are some challenges that they'll face if you ask them for an exception. So that's it for my formal presentation. I wonder if you have questions for me that I can answer for you. Are there any questions?
Excellent. Thank you for that incredibly insightful presentation. There were a lot of things that I had absolutely no idea about with regards to private drug plans. Yeah, so we'll be taking questions if you have any. I'm sure there are some that you can put forth to us. I've got one here that we'll start with. It's why are some drug plans or why are some plans more restrictive than others?
Bottom line, it's what the plan sponsor can afford for the benefit plan. So they get to really choose what coverage they want to provide, and they decide how restrictive. It's often about affordability, right? Like what can they afford with the plan that they want, and making sure that they can afford to pay for it.
And what about pharmacies? Because not all pharmacies charge the same amount for the same medicine? Is like, do you have the opportunity to shop around?
Yeah, I mean, that's a really great point, is that there's no price controls on what pharmacies can bill patients. And so, yeah, I mean, I strongly believe that you should check around for the cost of your prescription to different pharmacies for sure.
Can you speak to or about compassionate programs?
Not specifically, because that's not in the scope of private payers. Those are pharmaceutical companies that potentially offer compassionate drug. But as you can imagine, they can't offer free drug or compassionate drug to everybody because they would never make any money. So that's part of the challenge, right? Is that they can't offer that to everybody. But you'd have to ask specific companies what they offer.
What about, man, we're just going through these questions. What's an average cost per employee?
For
Kind of range in small private companies.
Oh, that's so dependent on the type of coverage they provide. And there's not a drug plan only rate. The rate is for all the benefits, so dental, disability, vision. So yeah, I couldn't even come close to telling you what that might be. Definitely in the hundreds of dollars per employee, but maybe even more.
And kind of along those lines, like where, for a small business owner, for a small to medium-sized business looking to cover their employees, or looking to set something up like this, is it just a matter of calling different insurance providers?
Usually, most employers work with what they call a benefit plan advisor. So they're kind of like your financial planner, your insurance broker, but they specialize in benefits, and they usually provide employers with guidance on what to look for, what kind of rate should I expect? And so they act as an advocate on behalf of the employer, and they're generally paid by commission. So there's usually no upfront cost, but rather they get paid by commission based on the plan design that they pick.
We have a question here about stage 4. I just lost it here. Oh man. The question asks, if stage 4 or palliative, will the provincial government cover the cost of medication if we don't have private insurance?
I can't answer that, unfortunately. My expertise is only with private insurance.
Could you answer perhaps like who to contact? Would it be your MPP, or who you would suggest as a first?
So depending what province you're in, some of the hospitals have drug access navigators that can help you figure out what kind of coverage is available to you. So I would suggest seeking that out or asking your oncologist.
That's a great question. How are very high cost cancer drugs handled in these plans?
It really depends on the plan design. There is usually a protocol for determining if a drug should be covered or not covered, and it's usually based on a combination of the value of the treatment compared to other treatments, and the relative benefits of that treatment. So there's usually some of those factors, but remember we talked about a formulary review committee, and each payer sort of has a different approach to formulary reviews. Sometimes the drug may be covered, but then the plan has a maximum and they may not pay over $10,000 or something like that. So it really depends on the plan, which is why I haven't been too detailed in my presentation, because there's just so many variables that can determine if you're covered or not covered. What I can tell you is most pharmaceutical companies that have high-cost drugs also offer what they call patient support programs that can help you navigate what coverage might be available to you. So I would suggest that you contact, you can ask your oncologist, you can see if there's Access Navigator at your hospital, but you literally can look up the 1-800 number for the pharmaceutical company and you ask them if they have a patient support program where they can help you navigate some of this.
That's a great resource. And is, you know, kind of, if somebody in is looking for lack of a better term, like your private insurance manual that you get, or that you would get at your company.
Your booklet, yeah.
Yeah, the booklet. Like there would be information there as well, right? For one to.
Not, yeah, it is, but it's not. It's very general. Like it might be saying you have 80% coverage for prescription drugs.
Right.
Which is not very detailed. So that's why you need to ask more questions.
Yeah. And that's where you're saying, you know, go to the your drug navigator if there is one available to you, or to speak to your oncologist for better assistance.
Mm-hmm. Yeah.
Do you think that advocating for a drug to be added to a public formulary has more or less value than advocating to an insurer for adding to their plan or formulary? Another question that we have.
I don't know if I can answer. I don't think I can answer that, because the methods of managing a public formulary are completely different than managing a private formulary. So I only know about private formularies, so I don't think I could comment on that.
There's so many questions coming in that I'm losing track of them. Man, this is yeah, this is great. Here's the next one. Would income tax have to be paid on a compassionate coverage of an expensive cancer drug?
Don't know the answer to that.
And just, I know I keep asking kind of the same question as a follow-up to these, but like where, for the questions that are out of your purview, like yours specifically, Suzanne, where would you suggest somebody go to get better answers?
So, you know, that last question, I would call Canada Revenue Agency.
Okay,
like,
that's
like, yeah, because I really don't know the answer to that. It's a good one. I just don't know the answer.
Yeah. We have another question here where this person asks, how long does it take for drugs to travel from Health Canada approval to the patients who need them?
Well, as I mentioned, you know, I have seen certain cases where certain payers may take 12 to 18 months to decide whether to cover a drug or not. And I've seen some covered in 1 month. So there is, I know there's some standards that have been published by, I'm trying to think of the organization, that they publish a report that shows how long it takes to get a drug listed in Canada on average. I'm just trying to think of the organization. Unfortunately, I can't remember the organization, but they did a study on that. But it's much too long. I'll say that.
Yeah, for sure. Another question from one of our attendees says, many cancer drugs are really expensive. A 20% co-insurance is a lot, maybe thousands of dollars. Are there other sources to help with these personal costs?
So again, I mentioned that some of the pharmaceutical companies have patient support programs, and some of them offer copay assistance. So they're definitely worth checking out.
Are there any insurance companies you find to be more or less receptive to advocacy?
No, I mean, I think that, to be honest, I would say that in my experience, there's not a lot of advocacy with insurance companies in general. People tend to focus their effort on governments, but in fact, a lot of the working age population are not covered by the government and are covered by private plans. So I think we, as patients and as advocates, we can do more, but I don't necessarily say that one company is better than others. In fact, A lot of them have commented to me that they've never been advocated to.
Hmm. Wow, so there's an entire sector, if you will, that we still have to advocate to for these drugs or for better access.
Yeah.
Right? Yeah, yeah. Um, is there any private insurance company that will allow patients with higher stages or increased stages of cancer to purchase insurance?
Individual insurance, are we talking? Are we talking health insurance or life insurance?
Um,
Does it set date?
Both. It doesn't specify.
Okay, so individual insurance, I didn't really spend a lot of time on it. In its principle, it tends to be very low maximums just by its nature. Because with group insurance, the employer and all the employees are sharing in the risk. So it tends to be more generous coverage and a plan sponsor is paying for it. But individual coverage tends to be less generous and not great coverage. So even if you could with your condition, it probably wouldn't be great coverage.
How about drugs that are not indicated for the person's type of cancer? Or are there any last resort approvals?
So most private plans don't cover drugs that aren't approved for that indication if they're experimental. Where I've seen some success is the doctor making an appeal and showing that they've exhausted every other option, as well as showing that although Health Canada hasn't approved the drug for that indication, there's a solid body of evidence. That's sometimes the best tactic. Doesn't mean they'll approve it, but it's sometimes worth it to go that route.
That's really good. If you're in a province where your cancer drugs are covered by private insurance, but you need a genetic test in order to get the drug, do you know of any private insurance plans that would cover these tests, e.g. in the time before provincial plans cover the tests?
Not in my experience, and in my experience, usually the pharmaceutical company will fund the test in the meanwhile.
That's great, man. We just blasted through so many questions. I feel like, pardon?
I said I'm glad I could answer some of them.
Yeah, yeah. I was just like they were just going and going and going, and I reached the bottom for now. So if there are any other questions, please feel free to type them in. You had your contact information up, I believe, at the end. Could you just flash that again, or share your screen again? Just if anybody wants to reach you personally, I assume by including your contact information, you're okay with that here, and you can get.
Yeah, I will caution you is that I don't have the ability to advocate for people individually, but I would be glad to have a general discussion if need be. Can you see the information there?
Yeah, we can see the information. So one of the things I've continually said throughout the course of my time with CCSN, and particularly this webinar series, is that the more information we have, every little bit of information helps, and every contact and every resource absolutely helps in helping us to navigate this journey. And so I really appreciate, I speak for myself, but also on behalf of CCSN, really appreciate you, Suzanne, and all the work that you're doing. Yeah, just because this is incredibly helpful and insightful information for us to know, and for our network to be aware of, as they navigate life with cancer and after cancer. So yeah, just a huge thank you for your time tonight.
Thank you.
And a huge thanks to you for attending our webinar tonight. This webinar is a part of a series that we're calling Cancer Survivor to Financial Survivor. We're actually hitting pause on this series tonight as we break for the holiday season. We'll be back in the new year with more great presentations and even more resources that will help you go from being a cancer survivor to a financial survivor. We'll be sending out registration information for these webinars early in the new year, so watch your inboxes and social media for that. A quick note about email: if you're not seeing our emails in your inbox, please check your spam or junk mail folder. We use a third-party email service, so check your spam and junk mail folders. Mark CCSN as safe or add us to your contacts list to ensure that they'll come straight into your inbox. As always, all of our previous webinars, including this series, are accessible on demand through our website at www.survivornet.ca/webinars. And yeah, I just thank you again so much for attending this, and feel free to share this resource once the link goes out to you in the email. Again, check your email, spam, inbox. But yeah, feel free to share this resource because it's really incredible, all the information that we're getting across these presentations for this series. Really, really appreciate it. Thank you for attending, and one more time, thank you to Suzanne for her time and expertise. Enjoy your night, everyone.